uh, for those co-chairs that are doing all the real, hands-on work that the task force does is done in those subcommittees. So I want to welcome you. I hope you get plenty out of this, and feel free to ask questions of the chairs. And again, welcome and thanks for being here.
Okay, thank you, Barry. And Kathy, if you could please make me a co-host. Thank you.
You should be able to share your screen now.
Oh, you enabled privileges. Perfect, even better. All right. Hi, everyone. My name is Jack Covenier. I'm the co-chair of the Incarceration Prevention and Reduction Task Force. And what Perry and I plan to do today is I'm going to take approximately 10 minutes to give you some history on the Crisis Stabilization Center. I know that's redundant for some of you, given the background you have, but for others, we hope that's useful. Then Perry, who is with the Whatcom County Health Department and the current chair of the Crisis Stabilization Facility Committee, is going to give an update on kind of the current status, the way the current facility is operating. And then we anticipate having a fair amount of time for questions and answers to try to go over information you might have. I think, Perry, is that about what we've agreed to, I think, as memory serves. Okay.
Absolutely. Thanks so much, Jack, and welcome everybody. Thank you for taking the time to come.
Yeah, thank you to everyone that's here. So I actually have some history with this facility. I think the need or the recognition, particularly on the substance abuse side, for a more robust facility, in my recollection, was first discussed in probably 2007 or 8 as part of what was called the Substance Abuse Advisory Board, which was later folded into more of a behavioral health board. We talked about that a lot. There were a lot of blueprints that came through, and I go back that far in time to indicate that this was a vision a long time in coming, that the health department particularly had been consistently championing. At that time, Jackie Mitchell was assigned to the Substance Abuse Advisory Board. This preceded Ann Deacon's tenure. And we had a lot of discussions about the need to do something more robust. As the years went by and the discussions with the county council continued, and the effort, I think, to end some of the siloing between behavioral health and substance abuse were recognized. A number of county council people, particularly, I'm thinking particularly of Barbara Brenner and Sam Crawford, really championed the idea that we needed to deal with both, as did the health department. That sort of became the vision of something significantly better than what we had that would address some of the needs in the community. When the Incarceration Prevention Reduction Task Force was formed, I'm going to pull this up. Hopefully you can see this. So this is the original ordinance. I'm going to try to blow up the part. Here we go. So if you look right here, this is the initial task of our task force. All this is about the Crisis Stabilization Facility. It says develop plans for a new or expanded crisis stress center for individuals struggling with mental illness and chemical dependency. It goes on with various things to do. And everything else was develop recommendations for new or enhanced programs relating to that. So the initial work of the task force was very much focused on this facility. And I think it's a good thing that the task force, because my opinion doesn't matter, has taken on some of the further responsibilities as we've had some success there. But I mention this because it really, to me, indicates how successful the county, the task force, the health department, and others were in bringing about this vision. So when we formed in, I guess, 2014, that was the one area that I think the task force had total consensus on, because we were formed in light of some conversations about a jail facility that did not have consensus among different stakeholders, different political entities, different members of the community. But I'd say the Crisis Stabilization Center did. Many of you know, probably all of you know Ann Deacon, who really did an excellent job of tracking the money. And unfortunately, the longer this thing went on, the more expensive. I mean, I remember the first budget for this was like, it was like 4.5 or 5 million. And I think the final budget was closer to 12 when the facility was done. And that's over a 10-year period. And the other real challenge with this facility that remains is the operational funding. So some of you also may wonder why 32 beds. Again, many of you may know this. I know Ms. Laudenbach knows it, and I know Perry knows it. But the 16 beds per side are primarily a function of Medicaid and the way Medicaid funding happens. So what we did in the county was say, okay, we're going to have two facilities, and in this case, we have, well, Perry will get into who's operating it, but it's really two different operators with kind of a common lobby area. But you have a 16-bed substance use disorder, what we historically would call a detox, and the other side is, I guess we would call it mental health respite, mental health first aid, but mental health respite, mental health emergencies. And through the lens of the Incarceration Prevention and Reduction Task Force, the goal was to reduce incarceration through the use of this facility. In a broader community lens, and I don't think I'm overstepping to say that the health department, county officials, and many members of the community envisioned not just incarceration reduction, but a robust facility for mental health respite and substance use disorder, in addition to the obvious benefits as it relates to incarceration prevention. So we, broke ground. Can't even remember when. I got a photo of it somewhere with a bunch of us with our shovels. I think it was 19, maybe. Yeah, because we weren't wearing masks, so it was just pre-COVID. It was built during COVID. I know we can go before masks, and it took a little longer, but overall it came out pretty well. The architect really worked with us to get some things that met the needs of our community. I guess the other thing I want to say before I turn this over to Perry is the challenge, and I really commend the health department and the administration in moving forward, is I believe it was $2 million. I could be mistaken on that number, but a significant amount of money was coming from a commerce grant that had to be used. If we accepted it, we needed to use it. And one county, it might have been Clark, it might not have been Clark, but it was somebody down way south, declined the money because they were afraid if they built the facility, they couldn't operate it. In other words, the staffing costs were such, they wanted to decline the obligation that would be presented from having the facility. Whatcom County took a little more risk. We had help from Sharon Schumake, who got, I think it was $1 million in operational funding, give or take, as well as representatives on both sides. Doug Erickson was in favor of it. I talked to him. We talked to Sharon. We talked to everybody that would listen. Ann was particularly effective at that. And the operational funding remains a concern. I think the efficacy of the facility is such that my hope is keeping it funded will be easier than getting it funded, but we're not out of the woods here. I mean, the funding issue, we're not out of the woods. It's not a sure thing because, and against the background of all this is all these BHOs and the way funding is done. I mean, everything changed about 4 times during the process we were building of how the state wants to reimburse for these kinds of things. So in some respects, it's kind of a miracle is too strong a word, but it's not necessarily typical in some places for government to be as innovative as this was to do it with the associated risks. And I think it's a testament to the vision of the community and the desire to have this, that it got done and is operating with a budget as well as it is. So that's kind of the history. That's why it's 16 beds on each side. This was not an overnight thing. These discussions were going on for a long, long time. My role, I'm a community or a consumer? But I'm someone that is supposed to represent and do represent some of the realities of the community and the need for these things. I'm a person in long-term recovery, which for me means I haven't used substances since May 1st of 1990, so a while now. But what I can tell you in that community, the recognition of a need for people detoxing, for coming off of opiates, for meth psychosis, for a lot of things is really, really significant. And the old facility, which I believe had 8 beds for substance use, was almost considered impossible to access. So if somebody were in a circumstance that they needed it, those people who, whether it was a police officer, a mental health professional, or a concerned family member or a fellow addict that wasn't as far down the road, weren't very confident that anybody could get in. And while they're still often full, I know of a circumstance just the other day where somebody had to be revived with Narcan. They got him in about 12 hours later. They couldn't get him in right away. They said, just keep calling every 3 hours. people come and go. This woman got in, and then they connected her to treatment in Yakima, which she went to about 5 days later. And she just was at a meeting I was at, had like 64 days. So the handoffs, I can't say it works 100% of the time, but anecdotally, I have seen that it has a reputation within the recovery community of kind of working, of being far more viable than it was. And that's important because it won't be used if people don't understand that it's accessible. So that's enough for me. I kept it to 10 minutes, Perry, I did it. All right, I'm back over to you. Oh, and if you have questions, if it's a clarification, I guess feel free to raise your hand or interrupt us, but we'll try to kind of do all of them at the end, I think is what we talked about if possible.
Thanks so much, Jack. That was a great general overview and certainly spans the period of time prior to me being with the health department and working with Whatcom County. Indeed. So what I'd like to do is provide just a little bit more detail just in regards to the individuals, the providers that are in the facility, a little bit about sort of the framework of what they do, and then talk about sort of the nature of the facility in terms of voluntary and involuntary admissions and those kinds of things that oftentimes come up. As Jack mentioned, this is essentially 2 16-bed programs under a single roof, total of 32 beds. That was really driven by the IMD rule, and that being, Medicaid will not pay for services that have a capacity of more than 16 beds. So we wanted to make sure that for both withdrawal management or detox and for mental health stabilization, that was obviously an accessible resource for individuals that were paying through a Medicaid process. The facility, the service program that does services, detox services in the Crisis Stabilization Center is Pioneer Human Services. They have a number of treatment facilities, programs, inpatient and outpatient throughout the state. And they are providing medically monitored detox services with a 24/7 nursing staff, which allows for on-site medical screening, which is new level of care for us, as well as admission to treatment. Previously, as I mentioned, medical clearance through the hospital emergency room was necessary, which created a number of different challenges and dynamics to admitting the individual, how quickly the individual could get admitted. They can also prescribe on-site prescription of medications that help alleviate the discomfort of detox is provided, and then administered by the nursing staff, obviously. There is also medication-assisted treatment available for individuals who are struggling with opiates, and this is typically a program of where it varies from individual to individual, as you can imagine, but a common length of stay is somewhere in the region of 3 to 5 days as an individual is admitted to the withdrawal management services. At that point, and throughout the time that the individual is within the program, the staff are working with the person to take a look at needs. As Jack had mentioned in his example, they're oftentimes trying to place that individual in an inpatient setting, which is commonly a necessary level of care. That can occur throughout the state. They arrange transportation, and identify the needs for that individual. The really nice part is too that they do have certified substance use professionals there and can complete an assessment and intake identifying needs and forward that to the receiving program. So that is the goal as the individual is admitted in that level of care, and also to connect them to those resources, as well as facilitate connecting them to resources within the community as they maybe return to the community from an inpatient setting that may be out of Whatcom County. Compass Health is the service provider that does the mental health stabilization on the other side of the Crisis Stabilization Center. Obviously, the services are oriented towards stabilizing an individual in any variety of mental health crisis that they might present with. The goal is to be able to support that individual, and also to determine with the individual. If a higher level of care may be needed, that would be facilitated, obviously, which could, for example, be placement at the hospital, and as quickly as possible, but oftentimes a very similar time frame from that 3 to 5 day period, an individual being connected to services that are within the community as they orient towards releasing. The mental health stabilization side also has a 24/7 nursing staff. They do medical screening as well for the admission. Medications are prescribed through that program and or coordination with medications that had historically been prescribed with the medical prescriber of the individual. Treatment services are predominantly focused on calming the crisis and planning the stability and resources within the community. And as I had mentioned, discharge preparations are very much oriented towards either relinking the individual to the supports that they may have been involved with in the past, or if for some reason they had not been connected to resources in the community, connecting that individual to ensure that there's a direct handoff to those services that are available to the individual. Currently, the Crisis Stabilization Center operates as a voluntary treatment facility. And this oftentimes the question sort of comes up for folks that they may confuse the Crisis Stabilization Center with a evaluation and treatment center, which is commonly an involuntary program. There can be voluntary components to it, but just for clarification, the Crisis Stabilization Center is a voluntary treatment facility. Clients can leave and discontinue treatment as they wish. The staff are trained in a number of evidence-based practices to attempt to continue to engage an individual that is obviously maybe struggling with a crisis situation or experiencing a really elevated emotional space. And so they are trained and oriented towards working through and motivating that individual to stay engaged, to stay involved in that process. It's a very nice setting. I don't think that I guess that we did mention, but they are individual rooms, whereas before, oftentimes the rooms were shared. So there's some privacy that is there. They do have a commercial kitchen within the Crisis Stabilization Center. And so the food is nice. There's a level of privacy. There's a level of quiet that they're obviously trying to provide. And so I just wanted to make that clear that on both sides, that it is a voluntary setting. If an individual wants to leave for one reason or another, the staff will certainly talk with them and facilitate whatever they can if the individual is leaving prior to recommendations from the staff, still facilitating that individual and having some resources and some connections within the community prior to their departure. As Jack had mentioned, the task force had highlighted the need for the Crisis Stabilization Center to serve as a diversion from arrest and incarceration. And as a part of that process, we've also begun a project of pursuing the ability for Compass Health, and I want to be specific about this. This is the crisis stabilization side of the facility, but Compass Health pursuing certification through Department of Health, which will allow a 12-hour law enforcement hold. I'm going to use that terminology. The Revised Code of Washington makes reference to this as being a involuntary placement, which technically it is, but I think that it confuses the matter. So I'm going to refer to this as a 12-hour law enforcement hold. There is a specific certification that has to occur through Department of Health for that provider to offer that service. And so there is a team effort in terms of Compass Health pursuing that. And I'll make reference to this if folks are interested in the details of this. This type of 12-hour peace officer hold is referenced in RCW 1031-110, as opposed to what most folks are familiar with is the civil code, which allows for an individual to be placed in involuntary treatment admission through our designated crisis responders. This is a bit different, and that is, again, what I'm going to refer to as this 12-hour law enforcement hold. So right now, the Compass Health is in the process of, actually pursuing this. And the design and concept and idea that the RCW 1031-110 allows is if an individual comes in contact with law enforcement, having committed a low-level crime, the law enforcement officer can essentially initiate a discussion with the individual to consider the alternative of going to the Crisis Stabilization Center as opposed to arrest and going to jail, short version of that. And if the individual does agree with that, the law enforcement officer will have the opportunity to transport the individual to the Crisis Stabilization Center, have basically an informational discussion with the staff at that point in time, clarify to the individual that they are at that point on a 12-hour hold and are required to remain at the facility. And that if they did choose to leave within that 12-hour period of time, that the facility would make contact with the law enforcement officer or the law enforcement officer's agency and inform them that indeed the individual had left within that 12-hour period of time and had, in fact, broken the agreement of a 12-hour law enforcement hold. So the staff would continue to work with this individual to not limit the individual's stay to a 12-hour period of time, but for the individual to remain until they had experienced the support that they could through the stabilization process. So essentially, a very structured method of using the Crisis Stabilization Center. And that would support, obviously law enforcement in their work. We hope that that stay for the individual would exceed a 12-hour period of time, but again, it turns into a voluntary stay at that point for the individual if they so choose. I see that Brell has a question, a hand up. I can stop at this point and we can answer a question.
Oh, thank you so much. I hope that's not disruptive. So appreciating this presentation. So on what you were just speaking about, is that applicable for both the detox and the mental health side? And also, like, if somebody comes into the jail and they're like showing signs of detox, is there a possibility to transfer them over to the detox center?
A great question. And so it is not applicable. There is not licensing at this point in time or certification being pursued by Pioneer Human Services that provides our detox services at this time. It would only be true for the mental health stabilization side. There are some discussions around that possibility in the future because the physical layout of each side of the Crisis Stabilization Center is actually exactly the same. They mirror each other. And so that is a possibility in the future. It's not something that's being pursued at this point. And to your second question in regards to the jail, I really can't speak to the jail's protocol and procedure if an individual is needing detox at that point in time, what their procedure might be. So I wouldn't be able to offer an accurate answer to that question.
Thank you, appreciate it.
You bet. Councilmember Hamel?
Yeah, a question in relationship to the breach of the agreement. To me, that sounds like it wouldn't trigger a warrant because that would probably have to be issued by a judicial officer. But what are the repercussions of breaking that agreement?
It's a great question, Councilmember Hamel, and I can answer at least from my perspective. Jack may have a little bit of a different answer as well. At that point, what the individual is at the risk of is actually being arrested for the low-level crime that they had committed, because, of course, an arrest and a jail booking hadn't occurred. I think that would probably be determined by the law enforcement agency at that point, and then, of course, in terms of charges and that sort of thing, would be the decision of the prosecuting office. So. That would be the end result of an individual departing within that 12-hour period of time. I see that Peter has his hand up. Peter?
Hi, Perry, and thank you, Jack, for your presentation today. I have wondered for some time now, the 16-bed rule, what is the limit to that? Can one stack numerous 16-bed facilities in the same area, and are there requirements that each be operated by different organizations, or could this Pioneer have two 16-bed facilities? What are the rules around that?
Harry, do you know?
So,
I was always going to ask Erica,
offer,
because it's a mess.
right. I can offer a little bit of information that I have at this point, because within the state, Department of Health and their certification and licensure for these individuals, it has been allowable across the state of Washington for a single building that had two distinct and separate services provided. So to answer the component of your other question, it actually could be provided. Services could be provided by a single entity, such as Compass Health or Pioneer Human Services in this given situation, but it would need to be two separate and distinct certifications and licensures, because they are different for each side of the Crisis Stabilization Center, and it would be limited to 16. We knew that there were some other facilities in the state of Washington that had already done this, and so there was a sort of a precedent that was set. Well, this is a relatively new arena that entities are entering into in terms of providing crisis stabilization services. And so we knew that we were able to proceed forward with that. Beyond that, saying 4 16-bed units, for example, or more, I suspect there is a very lengthy process of review and certification of the building, and then of the providers as well. And I don't think that the building would be approved in terms of the design if you were to have more than 2 16-bed units, nor would the funding probably be available similar to what we had as far as Commerce. So great question. That's as much as I know about it, and it is a bit of a still developing area because co-occurring disorder and IMD and those kinds of things, really challenging components. Great question.
Ann and I had a lot of conversations about this, because as a business person, it frustrated me. It seemed very arbitrary. And my understanding is the Medicaid rules won't provide funding beyond the 16 beds in most cases, unless you're geriatric. So it almost seems like a necessary political fix. What we've done reminds me of my propane tanks. I can't have a 300-gallon propane tank that close to my house, but I can have 3 100 ones daisy chained, So I think what I appreciate though is the county has, within, talking to the state, worked with the flexibility, because I think officials understand the inherent challenge with this. And I think we've been very good about staying within the bumpers that we need to stay in to have a facility that meets all the standards, while simultaneously trying to get what's best for our community. But I would agree with you, Perry, if you tried to do 80 beds, at some point, they're going to say that's enough. But we knew that the 216 sharing the common thing with the distinct licensures, distinct entrances, was going to fly. And I'm glad we were able to do that, because we certainly saved some money, and we're sharing a kitchen, I believe. So there's some synergy there. But this would be more one for Rick Larson and Susan Del Bonet and our senators, I think, to try to fix.
Right. And it's true. We not only share a kitchen and obviously some of the other resources that are coming into the facility, but also the two providers work very closely with each other, because we may have an individual that comes into the facility that is a co-occurring presenting individual, and their withdrawal management services that are needed present as a primary. But after that is addressed, it becomes evident that the individual is really needing some support from the mental health stabilization and possibly medication or connection to some resources there. And they can do a transfer. They cannot share patients because of the licensure and certification, but they can do a discharge and a transfer with a sign of release of information and provide the information that they collected from the individual in their admission to the other facility. So that's how the two different entities work collaboratively in that regard. So great question. I think that we'd answered the question for Peter. His hand is still up, and I wanted to be able to move on. That Michael Lillquist, you had a question?
Yeah, I think I have a pair of related questions that has to do with how law enforcement can serve as an entry point for this. You said that the 12-hour law enforcement hold was applicable when the person was suspected of a low-level crime. I assume that means the officer must have the usual legal standard of like probable cause or something like that, that they could actually arrest someone. And if they could actually arrest someone, then and only then can they use a 12-hour hold. If they don't have quite that legal threshold, then they can go the voluntary route. I just want to make sure that's clear. And what are the limits on them going the voluntary route? Are there any limits on an officer just asking someone to go the voluntary route?
It's a great question, and you are accurate from my understanding. The language in RCW 1031-110 does specify that actually the prosecutor's office has to identify and specify the low-level crimes that we're talking about, but indeed that individual could be arrested for that low-level crime, goes to the Crisis Stabilization Center, essentially has a discussion, and the law enforcement informs the individual at that point, you are on a 12-hour law enforcement hold, you are required to stay here, there will be consequences if you leave, do you understand, and having that discussion and so forth, and of course the staff being aware of that. Then hopefully the involvement and just the milieu of the setting, invites the individual to obviously remain, and every effort's being made, as opposed to threatening the individual, but every effort being made, because the person may not fully understand. It's conceivable that the individual may struggle with that, but there are no limitations per se in regard to an officer coming across an individual that they suspect might get into trouble because of where they are or what time it is, or maybe they are aware and know the individual from the past and could offer them the opportunity to be transported out to the Crisis Stabilization Center on a voluntary basis. And we are working with, I'll over-answer this question, but we're working at the process of streamlining the admission for law enforcement officers, limiting the amount of time that they need to spend there, but simply being able to take the individual out and drop them off. One of the things that we try and continue to communicate with all of our different law enforcement in the county is that there are some exclusionary criteria that really has to do with certification and licensure to the Crisis Stabilization Center. For example, if the individual's on oxygen, they legally can't have the individual there because they're not certified for that kind of thing. If there is a primary medical consideration that the individual really needs to be, needs to have that addressed at the hospital, they would be transported then to the hospital. Although we are working out the process of law enforcement dropping the individual off, an intake process occurring, and if for some reason a higher level of care is needed, then the provider at the Crisis Stabilization Center takes care of that transportation, oftentimes to the hospital at that given point because of medical consideration or oxygen or something of that nature. So there is no limitations beyond that.
Gary, it sounds like the police have a pretty free hand then in bringing people in. Okay.
Indeed, I would agree.
Thank you.
You bet. Atul, I see your hand up.
Hi, thank you. My question is about determining the number of beds. So what is the process by which this community would, Whatcom County would figure out what is the right number of beds for crisis stabilization and mental health?
Perry, do you mind if I take that?
Please.
Atul, I was the chair of the 1/10 Advisory Committee and the first chair of the Crisis Stabilization Center, and we had lots of discussions. And what determined the size was the rule about the 16 beds. I don't think anyone on the committee thought the perfect size was 16 and 16. I don't believe that. I mean, the reality is, at least on the substance use side, and Perry knows the utility rates better than I do, we could probably use 24 beds. I mean, I don't know what the numbers are exactly, but these numbers were not set because they were ideal for Whatcom County. They were set because that's what we could get funded. That's what we could get operational funding for. And that within the systems of government we're working in is what we could get. But if you were to ask me, what an ideal size would be, it would be significantly larger than what we have now.
And then, so why I worded the question the way I did was because I assumed that there's some kind of a prescriptive approach that was used, and you're doing the best you can, and that's certainly appreciated. So the question I'm asking though is, what is the process by which you discover what the right number is?
I think it's very hard because it's hard to measure who's not using the facilities you can't come into. That was one of the things we wrestled with, how many people were being turned away. And although that can be measured a little bit, that didn't take into account, for example, when we spoke to the sheriff and Bellingham chief of police and Ferndale, they said, look, we quit calling. I mean, so it's hard to measure what the utilization rate would be, knowing the very people who would use it aren't even trying to use it. I agree that data point would be very interesting. And I would encourage, if you want to come to the crisis stabilization facility meeting, we can, have a bit of discussion on this. But we had quite a few discussions, and this is one of those data points that's very challenging to get because you don't know who's not using what they aren't trying to access. I mean, you can make some broad statements. I can tell you anecdotally, in the recovery community, many people that needed a detox weren't even trying. In fact, the majority for a long time with the 8 beds. So I don't have, SAMHSA may have some data on this, and we relied on SAMHSA's best practices as we tried to gather this. If you look through VERA, that was more of the criminal justice, but there, the convergence between behavioral health and criminogenic factors is pretty high. I think they referenced it a little bit, but it's almost like trying to ask how many people have we diverted from jail. Sometimes other times you don't, because by definition, by diverting, they don't show. So I think that's the challenge with this data that I see.
Okay, and thanks for that invitation. And I would like to, I'll follow up with you. I would like to participate because the thing is, obviously as a SAC member, I'm not involved in the day-to-day. And so I'm thinking about how to contribute to the process. And for me, contributing to the process is trying to ask more questions that will hopefully stimulate processes that, where we right-size it, we right-size things. So I would look forward to contributing in that way. So
no, absolutely. I mean, Atul, I love talking with you, and I appreciate your desire to have that data. It would be great to have that data. And I'm not trying to be a naysayer. I'm just trying to give you a real brief view of the challenge I had and others had in trying to get that particular data set. But I understand how useful data is in making these kinds of good decisions for our community. Thanks.
Thanks. Brell's hand is up.
Thank you. Yeah, sorry to double dip. Just to follow up on the line or this question around what is the capacity. I guess I'm wondering if, and I really appreciate what you're saying, Jack, about the difficulty of really getting an accurate sense of need. But I'm wondering if it is being tracked, or if it's possible to track in the future around or if you have been tracking the data around calls that have come in to ask for a bed and being turned away because you're at capacity. I'm just wondering if that data is available around like just calls that have been coming in wanting a bed and that not being available.
I will let Perry answer, but I know this. I know that the task force has asked where possible for that type of data to be captured, but we've also asked if our requests are onerous and beyond reasonable staffing ability. We understand that everything we want can be produced. But Perry?
Yeah, it's a great point, and we did try, and so we do gather data in terms of referrals. Essentially, what we did was listed out that we wanted to be able to track referrals that were made by law enforcement, emergency medical services, our LEAD program, law enforcement assisted diversion, the GRACE program, which I think most folks are familiar with, our mobile crisis outreach team, also Peace Health, any jail transfers, other professionals that are in the field providing services to individuals in the behavioral health field, our community providers that weren't listed before, also self-referral or family referral, and then referrals from base camp. So we are, as much as possible, now this is self-report oftentimes, so accuracy in terms of the data, but in terms of doing an intake with an individual or a person calling, information is gathered about individuals that are referring. And then so also we do have a component of where the referral was declined for a variety of reasons, but for example, to your example, declined because the facility was at capacity. So we are tracking that and compiling that into a summary for that basically we get a monthly data input, and then we update that to something that just compiles it for quarterly, and et cetera. So we are gathering that information. The facility, as Jack had mentioned, has been open for roughly a year now. Obviously, that time frame also was coronavirus, and so there were some additional challenges. I really can't speak to, of course, what the data is beginning to show us and what the impact of coronavirus has had, in terms of those admissions and that kind of process. But hopefully that answers your question. We have not run into significant events of where the facility was at a capacity and the individual was not able to be admitted because of capacity at this point in time. But the potential is obviously there as we continue to develop and streamline our process, and the law enforcement and first responders are engaged in this, that is certainly a distinct possibility that we want to be able to track. So great question.
So in the past year that it's been open, there hasn't been much, if any, time where you've been at capacity that you had to turn people away.
I don't have all of the data in front of me, but I was reviewing it a little while back this week, and I believe that there were some situations on the withdrawal management side of where that it was at capacity, and that individuals were declined admission at that point in time. But typically what I know the provider does is that obviously the census can change, depending on an individual finishing, the length of stay that they need there or other events occurring. And so they're literally recontacting the individual at that point in time to facilitate a transfer. That wouldn't be, an admission, that wouldn't be reflected in our data, obviously. I just know that it's a practice of the provider.
And one thing I want to add is we've talked a lot about data in the crisis stabilization subcommittee and calls and the exact information we're talking about. COVID has really messed up these numbers. The pandemic, the masks, the social distancing, and a lot of other factors make particularly the early data for the first 6 months, I believe, very different than how it would have looked had COVID not been present during this. So I think as we hopefully move out of or adjust to the reality of living with COVID, the data we're going to see is far more reliable and will prove to reflect future trends. Whereas I think some of the past stuff simply just doesn't.
Agreed. Cliff, I see that you have your hand up. You're still muted, Cliff.
Okay. We're talking about arresting people on a low-level crime. My understanding is that the jail is not taking anybody that is not a serious crime. So if an arresting officer gives the person the option and they don't want it, they're not going to take them to jail. So then the 12-hour hold, you're gonna, I don't know, there's just, the jail is just over capacity right now. And my concern is that these people aren't gonna be able to get help, even if they need it, or even if the officer thinks that they need it, because there's nowhere to put them.
So it's you're accurate to my knowledge, Cliff, and obviously I can't speak to the protocols and procedures from the jail. To clarify, we are in the process of seeking the certification for the 12-hour law enforcement hold at the Crisis Stabilization Center. That's a fairly lengthy process, and there's a team that is working very specifically on that within Compass Health. So we don't currently have that certification, but I'll have more information as we sort of move along with that. And so right now, we continue to work with, on a number of different levels, the law enforcement community to inform them and give them information about bringing individuals out to the Crisis Stabilization Center for the services that they need, attempting to streamline that process where the law enforcement officer can do that very quick drop off and turn around to go back to patrol where they may be needed, very quickly. And so we continue to meet on a monthly basis with the Crisis Stabilization Center Advisory Committee, as well as other response systems committees and groups that don't necessarily have to do directly with Crisis Stabilization Center, but passing along that information that will take voluntary referrals as long as the person doesn't have, as I had mentioned, oxygen or some other situation going on that they wouldn't be appropriate for that admission. And then as individuals are understanding that it's a safe place, it's a good place to go, they're not going to lock you up, they're not going to lock the doors, the food is good, the rooms are private, etc., to facilitate that process and alleviate to some extent exactly what you're talking about of they're not going to arrest them, they're not going to take them to jail anyway because of kind of the dynamics that are going on with the jail. It is oftentimes conversations that we're having within with the providers and in the Crisis Stabilization Center meetings. So it's a great point.
Harry, I wanted to add, and I want to acknowledge Stephen's here, who's the co-chair, Stephen Gockley of the Incarceration Prevention Reduction Task Force, and I see Heather as well. This issue of voluntary and involuntary was a big issue for the task force because originally this was a strictly voluntary facility. I was not happy when I saw on the architect plans a room that could be used to restrain because we weren't going to have that. But in discussions, they brought in somebody, I can't remember from the state, I want to say his name was Peter, into the task force meeting and was convinced, and she certainly convinced me and others, and we brought this to the full task force, that having the ability potentially to have this 12-hour hold on, and this is only on the mental health side, not the substance use side, correct, Perry? And because I didn't want that to be conflated. I didn't want somebody detoxing to think they're going to be locked up, but on the mental health side, it really did make sense. And Anne, I believe, thought that having that capacity made our facility potentially more robust. The conversations as the use of that would be extremely limited, but also allowed our facility to potentially do things it couldn't do otherwise, which I think also helps with funding and operations. So there was a lot of discussion about this. And my recollection is the full task force, when presented with the options, unanimously agreed to go ahead and let that one side have the involuntary component, which was very different than initially what we had discussed or thought we were doing. So I just don't want anybody here to have the impression this is an involuntary facility, because it absolutely isn't. It's a voluntary facility that on the one side may have, and we are pursuing the potential for a very limited 12-hour hold.
It's a great point, Jack. And to further clarify that, the certification, even with certification for the 12-hour law enforcement hold, the staff do not have the certification to, for lack of a better word, to go hands-on with a client. They cannot subdue a client chemically. They cannot subdue a client physically in any given situation through the certification that they currently have. So essentially, the 12-hour law enforcement hold, it is not something that would be enforced in terms of some kind of isolation or involuntary status from a more sort of classic understanding of involuntary, similar to what's referred to as an evaluation and treatment center level of care. It's simply not that high of a level of care. Although those levels of care do exist, of course, if an individual is identified as being gravely disabled and or a threat to themselves or others, individuals that come into the facility are evaluated by a mental health professional, potentially an availability for a designated crisis responder where the person may be identified as needing an involuntary treatment admission, and that would be at the hospital at this point in time. So just wanted to clarify and reiterate what Jack was saying in terms of voluntary versus involuntary, because this is commonly misunderstood. So great question. Further question, Cliff, your hand is still up. I just didn't want to.
Oh, no, I just, I worked for the Sheriff's Department for 27 years. I retired 10 years ago, and I still have some familiarity with what's going on. And to me, we just need more facilities for some of these people. I can remember taking people in to the hospital because I felt they were a danger to themselves, and then find out 3 hours later the person was released and gone back home. Some of that stuff just becomes very frustrating to the law enforcement community.
I wholeheartedly agreed, and I just really felt fortunate to be able to work with folks may or may not be aware, for example, that the Sheriff's Office has specified behavioral health deputies that are very knowledgeable about behavioral health and are responding to individuals that are struggling with behavioral health issues. We have historically had designated officers with the Bellingham Police Department as well, and they've been crucial stakeholders in the meetings that I was describing that we have. The Crisis Stabilization Center Advisory Committee does involve law enforcement as well as first responders and providers for that input, challenges that are being experienced so that we get those different perspectives and really understand that. And so I think that that's going to be absolutely crucial to the ongoing success of the Crisis Stabilization Center, is that kind of communication and input, because those perspectives are important. Law enforcement want to know, where can I take this individual for the best care? Where do I go if it's at capacity? Those kinds of questions that can oftentimes get answered there. So it's a great point, and proud to work with the law enforcement representatives. Yes, Burrell.
One more capacity question. I don't know if you'll be able to answer this or not, but when you mentioned that when folks are on the detox side, that you try to get them hooked up with inpatient treatment afterwards, do you have a sense, or are you able to track sort of a similar capacity question? Like, are folks who are willing and wanting to go to inpatient treatment, how easy is it to find them a bed, or is that ever a barrier for folks, like there just being a lack of beds for inpatient treatment?
I do have some history and background in this. I don't know that I'm answering for, say, for example, the last year with COVID. There certainly were some challenges when there would be a COVID outbreak at a facility, and what the protocols and procedures were to protect the individuals and the staff and those sorts of things. The advantage that there is with the substance use disorder and with withdrawal management services is the Pioneer Human Service staff and any other staff that work in a detox kind of facility have pretty strong relationships with inpatient levels of care for substance use disorder across the state. And so they typically have very close communication about bed dates, available vacancies, next available vacancy. And so they stay in very close communication with them about did the 3 people that were going to admit to your inpatient facility actually show up? Do you have a vacancy today? Can we transport an individual? Because they already have a release of information for that person. So to my understanding, placement in inpatient treatment availability has not been an overarching issue, although that placement may occur outside of Whatcom County. We do have an inpatient level of care with Lake Whatcom for SUD services in Whatcom County. And I'm sorry, I don't know the actual what their capacity has been over this last year or so. But I know that we've worked with them very closely, and oftentimes individuals are placed in inpatient treatment directly from the withdrawal management facility at the Crisis Stabilization Center. So to my knowledge, that has not been an issue. Inpatient beds for mental health stabilization for individuals that are needing involuntary treatment admissions has been more of an issue. That's not something that I have a lot of data and detail to, but it's certainly a topic that continues to come up. So it's a great question in terms of capacity in our region and in our state.
Thank you.
You bet. I guess I can, sort of finalize this. Go right ahead, Michael.
Well, first, let me ask, I don't know how much, if we're in a full-on discussion period or if there's more presentation, because I don't want to step on further presentation.
The only other thing that I was going to share with folks is Jack had mentioned, there's some funding, issues with continued operations and so forth. We've been well supported by our representatives in that regard, at least for the time being. And so funding, proviso funding has been made available for provision of services at this point, and also for pursuit of the certification for law enforcement, 12-hour law enforcement holds. So I just wanted to make reference to the fact that we've been well supported by our representatives in regards to the needs that there were there. And that was something that I just wanted to make sure and get out there while we talked about it. So
okay, good.
Nothing beyond that.
That. So here's my question. Is the Crisis Stabilization Center more Band-Aid or pathway to cure? And one way you could tell this is how many people just cycle through repeatedly. In other words, maybe we can do them a good service for several days. And I don't want to downplay the importance of that. But if they then go back out into the community and things don't much change and they remain vulnerable and then they come back again, we're spending a lot of money, again, putting on Band-Aids rather than leading to a cure. So how much can you tell from those sort of revolving door data that it's helping only in the short term, and to the degree that it is only a short-term help and you're getting repeat customers, what's failing after the stabilization center that might need to be strengthened?
Very insightful question from my perspective, Michael. We do track individuals that are admitted that are unduplicated. So some of the data is being gathered in terms of this is a unique individual, they're not duplicated, that is within that period of time that they were admitted and then left and then readmitted and then left, dynamic. So I know that doesn't address fully, the scope of what you were talking about, but that's one way that we're able to capture it. I'm sure you're probably aware in terms of confidentiality, 42 CFR requirements in terms of protected health information, particularly when it comes to services that are related to substance use disorder. So there's some challenges around that, given that we're not the providers. The county, gathering data is not the provider, and also that protected health information. But I can offer also just from, I happen to be I'll lie and say a 25-year substance use disorder professional. It's longer than that, but that's as much as I'm willing to admit. And what I did end up, being able to discover is individuals, as you were describing, that would come in and do detox, but wouldn't necessarily accept the referral to another level of care to further that on. And then an event would happen, an individual that we've seen many, many, many times, and they actually became willing at that point in time for a variety of reasons to accept the referral and go on to a higher level of care, or an additional level of care. The fact that those services and the process of detox or mental health stabilization does include that referral to or re-involvement in the entity that is providing services within the community is huge. That has been a real challenge relative to, I think that folks are pretty aware, relative to COVID and also workforce capacity. That our behavioral health providers that were in the community were very limited in terms of what services they could offer, oftentimes virtual, and that sort of thing, particularly as we began to wrestle with the challenges of providing behavioral health services in a COVID, affected setting. And so I think that they adapted pretty well, and there is also continued development and a fair amount of resources being put into by the state and by other entities this workforce issue, because we're really recognizing that, yes, indeed, if we address the acute issue that is going on for this individual, it's absolutely imperative that we have ongoing support, care, and services. I would also say that the programs, including GRACE and LEAD, are pretty amazing programs to be able to hand back to. That is the case management and sort of wraparound services that are happening for that individual, so that they are being connected to services, including housing. And you can imagine, of course, the other components, literally even walking the individual to their appointments to ensure that they get to the services that are available for them. And so I think that it is effective, although clearly we are, as a matter of fact, working on a project right now that is about identifying the behavioral health services that are available in our community, and also those those services that are in need of additional resources, or those services that do not exist but are needed. Because we do not have enough receiving services at this point in time in the community, clearly. And part of that is, again, as I had mentioned, I think was really severely impacted by COVID. But a part of it is also just literally resources and services that are provided in the community. Workforce has been a real challenge, but at least I think that some of the entities from state to local have really taken that challenge on to ensure that we do have the professionals necessary to be able to provide the services. So hopefully I answered your question just in regard to that.
Barry, that was a careful and prudent answer. And I'm guessing when I ask you to be a little bit less careful, a little bit less prudent. You indicated, generally speaking, that there probably is a shortage of providers to refer to. You also indicated that for some individuals, part of GRACE or LEAD, they may have a case manager, but for others, I'm assuming there's no case manager you don't get one when you leave the crisis stabilization center necessarily. So, part of the larger picture here, I mean, my goal is to reduce the jail by making more robust the system that would treat people so they don't fall back into the jail. And we're looking now at the Crisis Stabilization Center as kind of a really key linchpin. And I'm trying to figure out if that's one of the stronger links in the system. And if it is, then is there a weaker link next to it? And is it those community-based services? Even if the Crisis Stabilization Center may not be as big and awesome as we'd like, that maybe it's one of the stronger links in the system. So can you be a little bit less prudent and careful and kind of give me some opinion here?
I think I can. And you're right. I have, for example, the opportunity to work with, we have a mental health court. I'm sure you're aware. We have some therapeutic courts as one example in the community. And what a lot of people don't actually understand is mental health court, I'll use that example. What it really consists of is just exactly what you were talking about. It is a case manager and a recovery plan or a care plan for the individual that the individual receives basically support to get to the services that are available within the community to ensure that they get there. And I see that as, for example, a really, really strong program. We also, I really agree with you that even though the services may be available, some of the individuals may be ill enough that actually getting to those services consistently and continuously can be a real challenge for them. And so that component, in my opinion, as far as case managers, whether that's with housing, whether that's with mental health court, whether that's with other services, is absolutely crucial for those individuals that we were originally talking about that tend to cycle back into detox or cycle back into the mental health stabilization side. Those individuals in particular, I think, really need those those particular resources. So hopefully I answered that a little more directly. I see that Council Member Buchanan's hands
I think he's
up.
going to tell us we're out of time.
No, I wasn't.
We're over.
We are, but I wanted to reflect on Michael's question as well. I think your question is important when you talk about what are the weak links that are being exposed if we have like you said, a strong link in the Stabilization Center. And that is going to be, I think, revealed in the work that Perry is leading through the behavioral health gap analysis work that's going on right now. That work group meets weekly, and they are going to be presenting to us on the meeting number 3 of the SAC, which will be June 8th. And that will be, hopefully some of that information will get more clearly identified, Michael, especially on the weaker links and what we need, where we feel those gaps are and what we need to do to fund them and create programs. Anyway, I would like to just say, I'd love to just say our presenters today were awesome. Jack and Perry, thank you so much. You gave a rich history and a great overview of the details and things that are going on in the crisis stabilization facility. And I hope all of you SAC members will be able to join the other co-chair meetings next week, and then our SAC meeting on Thursday. So again,
before we
go ahead, Jack.
that's all right. If you have other questions, you're welcome to email Perry or I, but also we meet the Crisis Stabilization Facility on April 21st. Those meetings are on the Incarceration Prevention Reduction Task Force website. You're welcome to attend. And that's also a great place to, if we know that you have a agenda item, we might be able to put it on there. And there's certainly a public comment thing. And, our goal on this committee is to try to disseminate as much information and answer. We know the more you know about it, the more you can plug this into the goals, the common goals we all have and what we're trying to achieve here. So that's another resource to you in addition to emailing us. Thank you.
Hey, Barry, I have another question. I just looked at my calendar for next week. I have 2 SAC meetings on my calendar. Is that right? One for Monday and one for Tuesday?
This is Kathy Halka with the council office. I can just clarify that there is a meeting on Monday and Tuesday. Those are the 2nd and 3rd group discussion meetings. And then the second stakeholder advisory committee meeting will be on the 7th, April 7th. So
3 meetings.
Correct. And I'd also like to just add briefly that if anyone has any follow-up questions, if you could email them to sac@co.whatcom.wa.us. What I've been doing is compiling all the questions we get from SAC members and posting them online so that those questions and answers can be available to all SAC members.
Thank you for the reminder, Kathy.
So again, thanks for joining today, and we will see you all next week, and have a great day and a great weekend.
Thanks, everyone.